Good afternoon. Thank you for joining us today for our virtual roundtable, Management of BPH Beyond the TURP. Before we get started, I'm going to share a few housekeeping items. Everyone on the call will remain muted for the duration of the presentation. At the end, we will open the floor for a Q&A. You can submit your questions at any time using the Q&A feature in the Zoom platform. For today's presentation on management of BPH Beyond the TURP, we are joined by Dr. Jeremy Kim, Dr. Sravan Panuganti, and Dr. Rebecca Gerber. Dr. Kim is a vascular and interventional radiologist at Charlotte Radiology. He received his medical degree from the University of Florida. He then completed a general surgery internship at Stanford University, a radiology residency at UNC Chapel Hill, and a vascular interventional radiology fellowship at Mount Sinai Hospital in New York City. He has focused his clinical interests and research in prostatic artery embolization, but he has also specialized in multiple vascular disorders and interventional oncology. Dr. Panuganti is a board-certified urologist with Carolina Urology Partners in Gastonia. His specialty interests include BPH and the preservation of sexual function, urinary incontinence, and erectile dysfunction. He maintains his academic affiliation at the Virginia College of Osteopathic Medicine, Carolinas campus. Dr. Gerber is a urologist with Atrium Health who specializes in the management of benign prostatic hyperplasia using minimally invasive endoscopic technology. She received her medical degree from Indiana University and completed her residency training at the University of Wisconsin. I'll now pass it over to Dr. Kim to begin the presentation.
Thanks for that introduction. My name is Jeremy Kim. I'm one of the interventional radiologists at Charlotte Radiology. I just want to first start off by thanking Doctors Panuganti and Gerber for taking the time to join me and talk a little bit about what I think are some of the best tools for BPH management. And luckily, we have all these options in the Charlotte area. Now, the reason I wanted to do this was because, a lot of us get patients who come in and we treat them, and one of the most common things that all three of us hear is that patients always say, I wish I had heard about this sooner or learned about it sooner. And we know that there are so many patients out there that are probably suffering with their severe symptoms. And this is in hopes of trying to get the message out and hopefully be able to help a lot of people. So first, I'm going to talk a little bit about BPH, and then I'll go into prostatic artery embolization. Of course, Dr. Panuganti will then talk about Aqua ablation, and Dr. Gerber will talk about HoLEP, and we'll have a little Q&A session at the end. So a little bit about benign prostatic hyperplasia, otherwise known as BPH. It is a hormone-mediated disease process that creates proliferation of the stromal and epithelial tissues within the prostate gland, and this can result in bladder outlet obstruction. And when you have bladder outlet obstructions, this can result in what we call lower urinary tract symptoms, or LUTS for short. And these symptoms are subcategorized into obstructive symptoms, which include weak stream, hesitancy, and retention. And the other subcategory would be irritative symptoms, including urgency, frequency, nocturia, and urge incontinence. This is the IPSS symptom score questionnaire that a lot of us use to kind of help decipher how bad a patient's symptoms are and kind of trend where patient symptoms are going before and after treatment. And, this is a pretty common disease. And in the US, it is affecting at least 20 million people. And this is from a little bit older data, but we know that it costs the US a lot of money, billions of dollars to help treat this disease process. And unfortunately, despite the prevalence, a lot of guys avoid treatment altogether, just mainly due to fear of complications. Now, this is the traditional treatment pathway that I think most people would manage these types of patients. And so based on the symptoms and physical exam, if a patient has mild symptoms, they go on to medical therapy. And then if you get a little bit more into the moderate severe symptoms, you may start inquiring about surgical therapies. And of course, in the medical therapy world, there are three main medications that people utilize, which include alpha adrenergic inhibitors, 5-alpha reductase inhibitors, and PDE inhibitors. And the quote unquote gold standard surgical therapy that most people know about is the TURP procedure. And we know that this procedure is very good at what it does, but it does come with some complication risks that include retrograde ejaculation, incontinence, hemorrhage, and erectile dysfunction. On the note of erectile dysfunction, I just wanted to mention that, there is a complex relationship between BPH and erectile dysfunction in itself. And then when you start adding on medication therapy and surgical interventions, that relationship becomes even more complex and can really affect someone's sexual function. And just a note, the TURP procedure is highly associated with sexual and ejaculatory dysfunction. Now, on to prostatic artery embolization, which is my procedure of specialty. We call it PAE for short, and this procedure's been around for a long time. It's been around for decades, most commonly used for bleeding. And in 2000, it was when we had our first published case report where Dr. Demare described it as a useful tool for treatment of BPH and urinary symptoms. Of course, thereafter, over the next couple of decades, there were numerous studies that came out, and in 2019, there was a consensus paper that highlighted all the data points that had collected up until that time. And essentially, the highlights are that yes, the procedure is effective for urinary symptoms, and those symptoms remained significantly improved at the 3-year follow-up mark. Most importantly, the major complication rate was very low, less than 0.5%. And that included a lot of early data, so early experienced users and things like that, and with over 2,000 patients. And of course, the risk of retroejaculation and sexual dysfunction was very, very low. There is no maximum size limit theoretically with PAE, and the studies did show that larger sizes were predictive of better symptomatic outcomes. Now, we all know that not all prostates are the same. There's different sizes and shapes, and the one subtype of that we talk about most often are the prostates that have large median lobes, or these glands that protrude into the bladder base. And those patients tend to be a little bit more symptomatic. And we looked at these types of patients in the PAE setting, and basically what we found was that there was no difference in clinical outcomes, whether or not someone had severe protrusion into the bladder or large median lobes versus non-severe. And in follow-up imaging, they actually found that the largest zone of ischemia and size reduction was actually in that the portion that protrudes into the bladder, affecting the median lobe more so than the peripheral areas. There are numerous minimally invasive procedures out there, and this is a meta-analysis that was published that reviewed all the randomized controlled trials for Resume, Urolift, Aquablation, and PAE. That meta-analysis essentially found there was no significant difference in early outcomes between any of these procedures, but the thing that they did find was that PAE and Aquablation were the most durable at 12 months' time. More recently, this paper was published in 2023 in The Lancet. It was a study that compared PAE versus medical therapy in patients who failed monotherapy, mainly alpha blocker monotherapy. And that study was a positive study in the sense that PAE provided more urinary and sexual symptom benefit than combined medical therapy, followed up to 24 months. Most recently, this year, this paper was published. It was another randomized controlled trial that actually compared PAE to optimal medical therapy on treatment-naive patients. And that study was also positive, demonstrating that PAE was more effective than combined medical therapy at reducing urinary symptoms, obstruction, and decreasing prostate volume. Additionally, they found that altered ejaculation and erectile dysfunction and nausea were more common in the medication group. So what is the PAE procedure? It's the same day outpatient procedure. It does not require any general anesthesia. I've done these procedures under moderate sedation or just even with local lidocaine for the access site in the femoral artery or the radial artery for patients who are very high risk. Procedure time is about 1 to 2 hours. Usually patients have more severe symptoms the first 48 to 72 hours, and they have mild symptoms for about a week. Clinical success rates are around 80 to 90%. And this is just a picture of the radial artery access approach. This is a sheath that's in the radial artery, and afterwards they receive this wristband that applies pressure at the arterial access site. And this is a patient giving us a thumbs up, showing that he's doing fine and feeling good. And this is a typical prostatic artery angiogram. So once we're in the artery, this is the catheter that comes down into the artery, and this is contrast material that we're injecting into the left prostatic gland, and this demonstrates the typical angiographic appearance. And from this position, we usually do the embolization procedure. In terms of embolization, we use multiple different products to essentially occlude the blood vessels that go to your prostate gland, and that starves the prostate of the blood supply that it requires. And over time, that helps the prostate shrink in usually a 3 to 6 month process. And this picture is just demonstrating a medical glue material that I utilize to occlude the vessels. And you can see the picture on the right is actually a intra-procedural CT that I take during the procedure itself, and all the high density stuff within the prostate gland is actually the glue material that I use to occlude the vessels, and we know that there's complete stasis there. As far as post-procedure expectations, I usually tell everyone that they're going to have urgency symptoms and some burning with urination. Rarely you do get some hematuria and hematospermia and hematochezia. All these symptoms self-resolve over time, like I said, usually over a course of 1 week. Potential complications could include a urinary retention. So if a patient comes in without a urinary catheter, they usually leave without a urinary catheter. In rare instances, I do have a few patients who go into urinary retention after the procedure, so they do need a catheter temporarily. Otherwise, the more severe complications like severe UTI or bladder ischemia or penile ulcers are rare events, but are potential complications. Again, I like to remind everyone that the major complication risk is less than 0.5%, and there's no risk of any blood transfusions required. So I'm going to conclude my portion with a case report that I published. This is a combined urologic IR case, a gentleman who had severe symptoms, really bad BPH. His quality of life was terrible. He failed multiple voiding trials and had an indwelling urethral catheter. And this is some cross-sectional imaging that we obtained at the time. And this patient's prostate gland size is 150 cc's. Just for reference, normal is less than 30. And as you can see, there are multiple high-density round structures within the bladder, which are multiple bladder stones likely resulting from urinary stasis. So the plan was to perform a prostatic artery embolization, shrink the prostate gland down, and then the urologic team was going to go in thereafter and do a stone procedure to extract all the stones. So the procedure went well, and the patient actually ended up removing the catheter himself at home. He was supposed to follow up with the urologist, but he delayed his care and actually reported passing more than 30 stones on his own. And his IPSS score went down to 5. His quality of life score was 0. And this patient actually was kind enough to send us a picture of all of his stones in sequential size order. But he did end up going to the urologist and getting a definitive procedure to remove the remainder of the stones, and the patient did very well. So where does PAE lie in terms of the urologic BPH space? I think there are lots of opportunities here. Of course, it's very good for bleeding or if someone's on anticoagulation, any patients who are non-surgical candidates or have multiple comorbidities. And I didn't get into too much of details on this, but PAE can be also complementary in the preoperative setting or in the oncologic setting, pre-focal therapy or radiation therapy, to kind of minimize some of the symptoms that someone may have prior to getting treatment. If a patient wants to preserve sexual function and desires a minimally invasive approach, this is a good option. And as now that we have data on this, patients who don't want to take medications or don't tolerate medications, this would be good for. And certainly patients with large glands and who are catheter dependent. So with that, I'm going to transition over to Dr. Panuganti to talk about Aqua Ablation.
Thanks, Dr. Kim. It was a great intro, great background on BPH too. If you ever want a second career, I think you'd be a great urologist. But we could go on to the next slide, please. So I'm just going to go over some demographic information. Like Dr. Kim mentioned, my data shows 12 million plus men actively managed for BPH every year. And continue, please. We have 4.3 million men do watchful waiting, which pretty much do nothing. They change their diet, kind of live with their symptoms. We have 6.7 million men that progress onto pharmaceuticals. We have 1.1 million men that have pharmaceutical fall every year and potentially delay surgery when they try these medications, and 400,000 surgeries per year. And this includes all BPH surgeries, from TURP to resumes to Aqua ablations. At one time in the US, TURPs were the second most common surgery performed in the adult men, only secondary to cataract surgery. And I think that might be because guys have 2 eyes, but only 1 prostate. Next slide. Continue. So that leaves us with 700,000 men eligible for BPH surgery that are left untreated. So we're talking about a massive pool of men that are suffering with their symptoms and may be delaying treatment and not seeking appropriate care, mainly because they don't know what to do, or they're fearful of having a TURP, which they may have had older friends or family members have done, and they didn't want to deal with some of the downstream side effects. Next slide. And 83% of men are not willing to sacrifice sexual function for symptom relief, which is one of the things that is sacrificed during TURP. So when we talk about BPH treatment options, the two main categories are resective and non-resective treatment options. So non-resective treatment options include where the prostate tissue is not removed during the procedure, something called the Urolift, which is very popular, or something called the Resume, which is often an in-office procedure, are the two most commonly done. These have low, they work on the right size prostate, but they tend to have a lower impact on symptom relief opposed to some of the more resective technologies, and poor durability as time goes on. But you have that trade-off that as these are quick and easy procedures, but may not have the lasting durability. So guys may need something done a few years down the road. They're otherwise pretty safe with minimal side effects, low sexual side effects as well, and low rates of irreversible complications. And when you do the procedure, you're kind of limited to the cystoscopic view, and you do have size and shape limitations to which prostates can be treated. When we talk about resective options, that's where we have our TURP, laser, green lights, HoLEPs, simple prostatectomies. So these have a high impact on symptom relief because we're removing a larger amount of prostate tissue, and aquablation falls in this category as well. Safety can be variable. You can have high rates of irreversible complications like urinary incontinence, ejaculatory dysfunction, erectile dysfunction with some of our older treatments and more invasive treatments. But something like aquablation really does bridge that gap and decreases the amount of these irreversible complications from happening. And traditionally, these older procedures had limited view cystoscopically. Things like prostatic artery embolization and aquablation allow kind of a secondary look, and I'll get into that, where you can see the prostate, kind of see what you're doing, and have both a cystoscopic view and also a image view, and kind of see what you're doing real time. And you do have size and shape limitations for TURPs and green lights, and the technique is also kind of based on surgeon skill and experience as well. Next slide. So prostates come in all shapes and sizes, typically broken down in small, medium, large, and extra large. Continue, please. And TURPs and green lights, which is PVP, were good for small prostates, but as you got to larger prostates, things like HoLEPs, also known as enucleation or simple prostatectomies, are more appropriate. Continue. And enucleation and simple prostatectomies are considered resective, like I mentioned, and they prioritize symptom relief, but you do have the trade-off of sexual function and continence preservation. And like I mentioned previously, 83% of men are not willing to sacrifice sexual function for symptom relief. Continue. And TURPs, green lights, water vapor, and Urolifts, they're for the small prostates, and Resumes and Urolifts, don't have much symptom relief, but they do prioritize sexual function and continence preservation, so you don't really have that side effect. But up until recently, we didn't really have anything that bridged the gap. Continue. And there was a clinical need to do that, and aquablation really does bridge that gap, where it can treat both small and large prostates while prioritizing sexual function preservation and minimal side effects. So aquablation, to kind of get into more detail, it's a newer technology that uses a transurethral procedure that has a high-powered 8,000 PSI water jet to ablate prostate tissue while having an ultrasound in the rectum as well. When I do this procedure, I almost feel like Dr. Kim, like an interventional radiologist. Not often do we as surgeons have imaging at the same time as we do surgery, and now we're able to have that. This can be done as an outpatient in select patients. We avoid intra-abdominal surgery, like things like simple prostatectomy or open prostatectomy would obviously involve. No evidence of postoperative erectile dysfunction in 450 patients in the original clinical trials, about 10% risk of ejaculatory dysfunction, where things like TURPs and HoLEPs and green lights had upwards of 70% risk of that. And this can be done in very small prostates to 30 grams and up to very large prostates as well, like I mentioned. And people think that this is a robotic surgery and they think this is a massive machine. It's not all that big. You can see me standing next to it. I have the smaller kind of screen is my ultrasound machine, and then the larger white one is the robot itself, where the cystoscopic aquablation handpiece connects onto. So it's not all that big, doesn't take up a lot of space. So this is the only image-guided robotic-assisted heat-free therapy for BPH. And kind of here, what you see with my images on the left-hand side, you see that ultrasound view of the prostate alongside the cystoscopic view. So I basically have two views at all times. And I set various treatment points. So I basically tell the machine where to start the water jet in important areas that I need to protect, like the bladder neck or the ejaculatory ducts are marked as well. So I know those are not going to be injured during the procedure. And then all the way on the right, you can kind of see that nice big open channel on the ultrasound view and also on the cystoscopic view as well. And this is all done with a robot. I tell patients this is the most boring surgery I do because after I set the robot in place, I just step on a pedal and everything else does the work for me. Next slide. So the original 4 clinical trials were the water study, the water 2 study, open water study, and the Francois water study. That included 425 patients with prostate volumes from 20 to 150 ml. And when we look at them in a 1-year follow-up, next slide, or continue. Yep, we look at the improvement in their IPSS score, which is that validated questionnaire that Dr. Kim mentioned. We see an improvement of 16 points, a peak urinary flow improvement of 20.5 mLs per second, which is very good. Quality of life improvement of 3.3 points, minimal post-void residual, and like I said, ejaculatory dysfunction down to 10%, which is much better than we had previously. Erectile dysfunction doesn't happen, and very low risk of urinary incontinence. Continue, please. And then what water 2 and open water did basically compared compared Aquablation to TURP, which is the historical gold standard, right? Urologists have been doing TURPs for 100 years. And when we look at IPSS point reduction in the 5-year time span, we're looking at 14.1 improvement versus 10.8 with TURP, low rate of complications, irreversible complications such as ejaculatory dysfunction, and fewer retreatments with Aquablation opposed to TURP as well. Continue, please. So when we also compared to other treatments, including green lights, simple prostatectomies, and HoLEPs, you can see, each of those treatment options have a different size where it's generally treated, but you do have enucleation. Dr. Gerber might argue with me on this one. In here, these studies show as high as 33%. I think that's higher than it actually is. I probably think it's closer to 10%, but she's the expert and she'll correct me later on. You do see erectile dysfunction as high as 14% and 20% with the green lights or TURPs, just because those are using heated technologies and you're having thermal energy on the neurovascular bundles while you do your resection. And then you have ejaculatory dysfunction pretty much present in all those other treatment options, which are pretty high, upwards of 50 to 90%, whereas with Aquablation, it's down to 10% because of the lack of a lot of heat during the procedure. Continue, please. So when we talk about safety as well, as we mentioned, prostates come in all shapes and sizes. Something called the median lobe does change our treatment management based on its presence or absence in a lot of patients. So when we look at patients that have a median lobe, the open water studies in water 1 and water 2 included, a lot of patients, over half the patients with median lobes, and you can still see these low rates of irreversible complications with incontinence, erectile dysfunction, and ejaculatory dysfunction compared to TURP, especially in the water 1 trial. Continue, please. So the other thing we need to be concerned about is durability. We mentioned we have some minimally invasive therapies that worked for a few years but lack durability. So this is 5-year data, and you can see that you can continue. I think you can click one more time. Compared to drug therapy and non-resective technologies, these are the blue, teal, and dark blue lines are Aquablation 5 years out, and you see IPS reduction in the TURP as well initially, but you start to see that yellow line creep up higher than it does for any of the Aquablation trials. So this shows that we have good durability, long-lasting durability, and less failures than you do with TURP, and obviously better than medications or non-resective technologies as well. Continue, please. And Aquablation has a 1% average annual surgical retreatment rate, so again, very low. And then when we also compared to Qmax score, which is your urine flow rate, you can see in the water 2, and open water, as well as TURP, you have a nice reduction of Qmax, and you can see that is maintained at 5 years and obviously better than non-resective and drug therapy as well. So the Canadian Urological Association has a very nice online patient decision aid. And a couple of years ago, they published their data from 10,000 patients, and prostatic artery embolization was not included because that's not a procedure urologists typically do. But basically, it surveyed these men and compared aquablation and nucleation, green lights, open and robotic prostate removal for average improvement of urinary symptoms. And you can see that, aquablation, nucleation, green lights, and open prostate removal are pretty high. However, your recovery rate from aquablation is much faster than prostate removal, and you don't have the side effects of erectile dysfunction, ejaculatory dysfunction like you do with green lights and enucleation. So it's comparable with the average improvement with urinary symptoms. And you can see on the right side of the screen, on the quality of life, it's up there with everything else as well. Next slide. Oh, and then I'll hand it over to Dr. Gerber.
Hello, I'm Becky Gerber. Thank you, Dr. Kim and Dr. Panuganti. I'm going to sort of skip over the basics of BPH and how many men it's affecting in this country because they already covered it for me. So we're going to jump straight to talking about HoLEP, or holmium laser enucleation of the prostate. So this is a minimally invasive endoscopic surgery that I do. We use the holmium laser to remove all the obstructive prostate tissue. So if you think of a prostate, we can go to the next slide, like an orange. This is how I sort of describe it to all my patients. With a green light or a laser TURP, you're basically going in and you're scooping out the adenoma from the middle channel, from the urethra. But with the HoLEP, you're actually cutting into the prostate between the transitional zone and the peripheral zone. You can go to the next slide. And this basically cores out all the blocking prostate tissue. So instead of just, like a TURP and a green light, you're sort of blindly resecting until you think you've removed enough. The HoLEP actually allows you to get in this really nice plane to remove all of the transitional zone. All you leave behind is the peripheral zone, which doesn't typically grow back. So it's very good at removing all of the obstructing tissue. Next slide. So why HoLEP, and who is a good candidate for HoLEP? So I think the biggest reason is the excellent symptom relief that patients have and the durable symptom relief. I have done a little over 500 of these now since I've been with Atrium, and just the number of patients who come up and tell me like they're so grateful, they're so happy. It's a very rewarding surgery to be able to do just because of how well patients do after and how happy they are. I just had a patient the other day tell me he was going to get a shirt that said, "Ask me about HoLEP," and wear it around so that he could tell other people about it. And I get a lot of referrals from neighbors or people they go to church with or golf buddies because they do well. And then they say, I've had these symptoms for so long. I've been suffering for so long. I don't know why I didn't do this earlier. It's a very versatile procedure, which I'll talk about in a little bit. It can be done on a wide age range, a wide size of prostates, patients on anticoagulation. It is endoscopic, so it's minimally invasive. There's no incisions. It's all done through the penis, through the urethra, and it's outpatient in a large majority of cases. So they come and leave the same day. Very low risk of complications with the HoLEP. And then everything that we remove, we can actually send off to the pathologist to check for prostate cancer, which isn't typically a concern, but it's nice to have to be able to analyze. Next slide. So to start off talking about the symptom relief. So HoLEP is not new, really. It's been around since 2000. It originated in New Zealand, and they started doing them at Indiana University in 2000, and it sort of spread and become more common since then. So this is a lot of randomized controlled trials that they've compared HoLEP to TURP. Like Dr. Panuganti talked about, sort of everything is compared to TURP because that's the gold standard, although I'd argue at this point, like no one really needs to be getting a TURP. So this is just showing that we talked about that IPS score, that's that questionnaire. So this is showing that people have pretty significant improvement in their IPSS score with HoLEP. And then the Qmax, that's their flow rate. So how their flow is after surgery. And most of the guys tell me they're peeing like they're 20. They use a lot of analogies to fire hydrants and things like that. So they're very happy with their flow rate after the procedure. So the symptom relief is great. I think that the biggest thing about HoLEP is how durable it is. So since we've been doing this since 2000, there was like a big randomized controlled trial that came out about outcomes in like 2019, 2020, and that looked at 18 years of data, and the retreatment rate was less than 2%. So this is, like I talked about, you're really removing all the obstructive tissue and there's not anything left to grow back. So the retreatment rate with HoLEP is incredibly low. And I tell patients, if we're doing this procedure, this is the only thing you should ever need. You shouldn't ever need another procedure ever again on your prostate, which is obviously very reassuring for a lot of men. It is a very versatile operation. So in theory, you can do any prostate size. So far in my practice, I've done any size from 30 grams to 350 grams. I know some colleagues who have done up to 500. So you really can do any size prostate. You can do any age. I've operated on someone as young as 43 who had an enlarged prostate, and then a few weeks ago I did a 91-year-old. So you can do it on any age patient. It's really, really good for patients in urinary retention. So I think there was this old sort of view that if they have a catheter, their bladder doesn't work and there's no hope, they have to have a catheter forever. That is just not true. I've done a HoLEP on someone who had a catheter for 8 years, and that was a year ago, and they're still voiding spontaneously with a low PVR. So I would strongly encourage you, if you have any patients in urinary retention, consider sending them for any of these procedures, because they don't have to suffer the rest of their lives with a catheter. And it also can be done with patients on anticoagulation. So if patients are on, Eliquis for AFib and they have a pretty low stroke risk, I'll usually hold it. But if they have a history of clots or some other reason that they need to be on their anticoagulation, you can keep them on their anticoagulation through the procedure. Like I said, it's endoscopic, so they don't have any incisions on the outside, which really helps with recovery. It's outpatient in the majority of cases. Sometimes there's some social issues, or if patients have a lot of comorbidities, they'll keep them overnight. But vast majority are performed as an outpatient. They just have the catheter for one night. So we do the surgery, they go home with the catheter, they come into our clinic the next day, we take the catheter out, and 95% of people pass their voiding trial on the first day. So very short time with the Foley catheter. And I don't really know how to explain it, but minimal pain. I mean, really, patients are always shocked about the amount of the lack of discomfort they have afterwards. It does seem like it would be, somewhat uncomfortable, but really minimal burning, minimal pain. So people, feel pretty good within a few days after the procedure. Very low risk of major complications. So like I said, I've done a little over 500. I've only had to transfuse 4 people. 2 were on anticoagulation. 1 had an undiagnosed von Willebrand's that we figured out after. And then 1 other patient who had a transfusion. So the risk of a blood transfusion with this is very, very low. And there's really not a lot of other major complications. There's a very small risk of bladder injury. At the end of the case, you use a special device called a morcellator that goes in the bladder to suction the prostate and remove it. And you could theoretically injure the bladder with this. Knock on wood, I haven't had this happen yet. There's ways to do it safely, so the risk of that's pretty low. And then the other, side effects like UTIs, I mean, these things happen, but they can be corrected pretty easily. And I wouldn't consider that a major complication. So, I think a lot of people like to dog on HoLEP for incontinence. And I think that you really can predict who's going to have issues with incontinence. So patients with uncontrolled or poorly controlled diabetes, patients with a high BMI, patients who have, are in their 80s or 90s, patients who have gigantic prostates over 300, these are the men who I talk a lot about beforehand. You're going to leak for a while after surgery, maybe even 3 to 6 months, maybe longer, just because of your pathology as a human. But the generally healthy 50, 60-year-old, 70 men with prostates under 200, they have incontinence for a few months, but they work on their Kegels, they see pelvic floor PT, and it goes away. So, I think the risk of incontinence is there, but having done the number that I've done, you can sort of predict who it's going to be an issue for and who's going to be fine. And I've had some very motivated 80-year-olds who see PT before and they work on their Kegels and they only have incontinence for a few weeks. So I think in motivated, educated patients who are, willing to work on the Kegels and CPT, they do really well. And I can kind of tell now who, is going to struggle or take a little longer. And I just talk about that beforehand. The other thing that I think, HoLEP is maybe a disadvantage, or people sort of talk about comparing it to other things, is, I mean, most patients will have retrograde ejaculation. The reason is because the HoLEP is removing so much prostate tissue. If you're going to remove all of the peripheral zone, you're not going to be able to ejaculate because there's no prostate tissue left to push the ejaculate out of the penis. And so, I mean, the reason that there's a less than 2% retreatment rate at 18 years is also the reason that they have a lack of ejaculation. So I sort of tell them, you know, this is going to happen. I would say when I see people in follow-up, about 90 to 95% of men still feel like their orgasm's the same, their erection's the same. It's just when they ejaculate, it comes out in the fossa, falls back in the bladder, and comes out when they urinate. So they just don't have the ejaculate come out. Probably, in my opinion, like 5 to 8% of patients feel like the lack of ejaculation diminishes the sensation of their orgasm. And I don't really know why that happens to some people and not others. So it's just something that I'm very upfront about with patients, that it's going to happen. Most patients will feel the same. Your erection shouldn't change because the depth of penetration of the laser is very shallow. So it shouldn't affect the nerves around the prostate, but I mean, they will have retrograde ejaculation, and that will be permanent after, and just a consequence of removing so much prostate tissue. You can Google this. This is on Google. This man was very eloquent in his words. And so I just think, sort of to summarize what all of us said, is that there's a lot of options for BPH at this point, and men don't need to suffer. They don't, you know, they've heard a lot of scary things about TURPs, and really there's no reason for them to even have to have a TURP anymore. There's a lot of other more minimally invasive, durable options that can get them symptom relief, and they don't need to be on medications forever. And so I think, you know, it's worth it for patients' quality of life. The sooner that we see them, the less damage to the bladder over the long term, the better they will be. So that's why I think we're all here, is just to help these patients get better more quickly. Yeah, this is basically a summary of everything I just talked about. I have some videos online, basically just me going over the HoLEP procedure. So that's what that QR code links to, or if you have any other questions about HoLEP.
Great. Thank you so much, Dr. Kim, Dr. Panuganti, and Dr. Gerber for this extremely informative presentation. Just again, as a reminder, if you have any questions that you would like to ask, you can use the Q&A feature in the Zoom platform to submit your questions. While we wait for people to gather any questions, we had a few submitted during the webinar that we will address. So the first one is, does my patient need to have tried and or failed medical therapy before treatment?
Should I take this one?
Yeah.
Go for it.
We can both take it.
Yeah.
But I think that the answer to this question is no. They don't have to start Flomax. They don't have to start finasteride. If they're having symptoms and they say, you know, once they start those medications, they're going to be on them for the rest of their life. So if they don't want to be on medications forever, it is totally reasonable for them to have one of these procedures before starting medical therapy, so that they don't have to be on those medications, have the side effects, have, you know, maybe their bladder progress and develop damage. So definitely do not need to fail medical therapy before they come and see one of us.
Yeah, and to piggyback on that, I know a lot of primary care doctors, have a patient that come in with the symptoms and you want to do something for them, right? And absolutely, before they can get their office appointment to see, one of us, start medications. There's nothing wrong with that. But I think our goal, with Dr. Kim and Dr. Gerber and I, is to get guys off medication. Often what I tell guys is nothing makes an old guy feel old than taking a handful of pills every evening, right? So if we can peel off some medications, 1 or 2 pills a day on a guy, I think that's a massive improvement. And I think us as urologists and primary docs, we've all fallen into a trap that a patient comes in with a complaint, you treat it with medication, and you think that complaint is addressed, and it's not always treated. And we've seen a lot of beat up bladders that have weakened over time with people thinking they're treating a man's enlarged prostate with medication, but as time progresses, the bladder gets weaker and cannot push out urine as easily, which makes surgical outcomes not as great. So I think early intervention, preserving bladder health, is imperative for a lot of these men.
Yeah, and obviously the urologists know more about this bladder health, but I think that is a key component to this, right? Any sort of bladder outlet procedure is more effective when the bladder works. And of course, just to echo what I mentioned earlier, we as far as the PAE side, which I think is can extrapolate to any bladder outlet procedure. We have trials that demonstrate randomized control trials that demonstrate the superiority of PAE versus medical therapy alone. And that obviously translates probably to any sort of bladder outlet procedure.
Okay, the next question is, how do I know which procedure to refer my patients to?
Yeah, I think that's a good question. And I think our goal between the three of us is not to throw out three competing products and say, pick ours, ours is the best. I think our goal, and I think Dr. Kim and Dr. Gerber would agree, is to educate everyone to know that there's treatments out there. And, in my mind, when I give these talks, I usually say the TURP is a dead procedure. So if a patient is reluctant to seek a referral to a urologist or interventional radiologist because they don't want to end up with a TURP, you can confidently tell them they don't really do those anymore. That's an outdated procedure. There's a lot of newer, cool treatment options that are in and out, or, don't have a lot of sexual side effects that you should at least go to talk to someone about. And I think the goal of all of us is just to educate the public that, you don't have to pick and choose, you're not picking off the menu here, but just be aware that there's options out there. And there's men that all three of us have seen. We have educated patients that have seen Dr. Kim, we have a group text, and we talk, oh my God, like this guy saw me too. And it's actually quite funny because these educated patients have gone out and seen the experts in the greater Charlotte metro area and gotten their opinion from each technology.
Yeah, I think
Yeah, and I was gonna, sorry, go ahead.
Dr. Kim, you go.
You go ahead.
Okay, so I agree with everything he's saying. I think all of us have what's best in mind for the patient. So I'll sometimes send people to Dr. Kim or Dr. Panuganti if I don't think they're a good candidate for a HoLEP for some reason, and they'll send patients to me. So I think if they end up in one of our clinics, they're in the right place because we'll get them where they need to be. So I think it's just important that they see a urologist who is, up to date on the latest technologies and is willing to say, maybe I know how to do a TURP, but there's these other procedures that are better, and I can help you decide what option is the best for you. And so I think that's what's the most important thing.
Yeah, and I was just going to add, like every procedure has its positives and negatives, and I think one of the things that is really important is just talking to the patient, figuring out what their objectives are, what lifestyle do they live. Sometimes, just because you're 90 doesn't mean that you have the same objectives as a 70-year-old, and a 70-year-old might not be as active as a 90-year-old, and we just don't know what that means. And certainly in terms of sexual function, everyone's got different experiences with that too. And so we can really tailor it to each individual's needs. And I think each one of these procedures has its advantages and disadvantages. And I think it's more of not a competition, but what's right for each individual and what's right for each person's, life goals. And I think that's where I think this comes in terms of the discussion.
Great. Well, we haven't had any more questions come in. Is there anything you would like to add as a final note?
Yeah, I mean, and this is, I want to highlight Dr. Kim here because I think Dr. Gerber and myself, we have an advantage when a patient comes into a primary care office and they come in with the urinary issues and they may have failed medical treatment. The obvious thing to do is to refer to a urologist, right? And the thought wouldn't always be like, maybe I'll refer to an interventional radiologist to consider prostatic artery embolization. So, I guess this question's to Dr. Kim, what do you want primary care doctors to do? Do you want them to refer to you directly? Do you want a urological evaluation first? I mean, what's the best way for patients and providers to come out and find you?
That's a good question. And I find myself in this situation often in terms of not just primary care doctors, but patients come in who have seen other urologists and they're unhappy with the options that they were provided by their current urologist. And then, you're playing this game of, well, do I have this patient go see another urologist? But short answer is I don't mind if the patients come straight to me. You know, I'm going to do what's right by the patient, and certainly I will send patients to back to their urologist to, hey, I need this type of workup. Let's talk about this a little bit more. I think the main thing is just making sure that the patient sees somebody that is a little bit aware of what all the other options are and has the connections to be able to get patients in the right places so that they get the appropriate treatment that they're required and the workup that's required. So either way works for me. I don't mind one way or the other. It's just a matter of just trying to figure out what's right for the patient and what the patient wants to do.
Great. Well, thank you all for your questions and contributions. If we don't have any more questions, we will conclude at this time. If you have any further questions, please feel free to reach out to any of these physicians. Their emails are listed here. A follow-up email will be sent of today's recording of the roundtable. It will also be posted on the Charlotte Radiology YouTube channel and website, so you can refer back to this presentation. Thank you all again for your time today. Hope you have a good rest of your day.
Thank you.
Thank you.
Thanks.